So now you get me. As I mentioned, I'm going to talk about DoxyPEP for about 10 minutes. From a community perspective, I'm not a doctor, I'm not a healthcare provider, I'm just a person who's been promoting DoxyPEP for a really long time. So I'm going to talk about that for about 10 minutes, and then I want to talk about when I was just at a conference in Sydney, and they presented some data from Fiji, which was really alarming. And so I have some screenshots of that, which I'd really like to share with you, just so you're as alarmed as I am, and maybe something can be done. So anyway, DoxyPEP, here we go. So DoxyPEP, doxycycline used as post-exposure prophylaxis. That's pretty much what it is. Stop STIs with doxycycline. And one dose can cover up to 3 days of sex. So if you take it on Sunday night, it will cover your Sunday, Saturday, and potentially Friday. So that's how it works. So it's effective, it's been studied, and yeah, so now we need to get the word out. So, oops, wrong button. So doxycycline has been used for lots of things over the time. So here are some of the examples: used for skin conditions, it's used for rashes, it's used for prevention of malaria, all kinds of things all the time. It's been used for ages, it's been around for a very long time. It's a fairly innocuous antibiotic. So here's an example of someone, so Oracea is a product that they use for rosacea, so skin, used quite happily and freely, and people have been on it for a long time. I suppose someone's been on it for 3 years, you should take breaks. So that's how they used it for skin. So it's been used a lot, all the time, studied a lot. So in terms of, I have a little video here. Maybe? No. Yeah. Theoretically, video is playing. It says it's counting down, 1:43, and now I just go to oh, here we go.
What DoxyPEP is taking 200 milligrams of doxycycline 72 hours after exposure or potential exposure to infection.
Just take 2 pills of doxy, 200 milligrams, after sex, and it will drop your risk by 70 to 80% for syphilis and chlamydia, like it's crazy. Only for men, the data for women isn't so great.
I don't use DoxyPEP with my life partner, but because we are in an open relationship, we have an agreement on using DoxyPEP when either of us have a casual sexual partner. So I guess this is similar to negotiating condoms outside of your open relationship.
So it means if you're having sex Friday, Saturday, Sunday, you can take 2 pills on Sunday, and that will cover all those activities.
So DoxyPEP has got some real potential to change the way we look at syphilis management. There's been some really, really good studies.
And they're recommending its use because syphilis is epidemic, and we need to do something about it. So what you need to do is talk to your doctor, refer to the New Zealand Sexual Health Society guidelines, and they'll give you some recommendations on how to actually get it. And at the moment, it's going to be off-label use, but because doxy's used for everything, your doctors should be able to prescribe it fairly easily.
I had STIs in the past. Since I've been on DoxyPEP, I haven't got any STIs, and I think that's wonderful and very liberating.
So there you go. So that's how it works. So the idea is that, as mentioned, this is one of the first tools we've had in a really long time in terms of looking after syphilis. So we haven't had a lot of other tools around. And as mentioned, here's your syphilis rates, like they're off the charts. So syphilis, I think Sunita called us the city of syphilis at one point a few years ago, instead of the city of sales, and that's still true. So syphilis is pretty epidemic, and this is a tool that we now have available which can change that trajectory. And so what we're seeing in places like San Fran, Paris, places like that where they've had DoxyPEP fairly accessible, is that they have seen a huge decrease in their syphilis cases. So your target audience is going to be someone who's most at risk of getting syphilis, so whoever that is, but an indicator would be, I would say, people on PrEP, for example, or people who have had syphilis before, or their communities of people who they're connected to, right? So if you're seeing networks of syphilis transmission, the way to nip it in the bud is they'll do DoxyPEP and it disappears, right? So it's really good to engage in. So that's the challenge. Is syphilis is epidemic. That's when you look at it by breakdown by MSM, that's one of the big target audiences. There's lots of syphilis amongst gay guys, and it's been there for the longest time, and it's still there, and this is one way we could deal with it. In terms of, this is the chlamydia thing, so DoxyPEP works really well with syphilis and chlamydia, so about 80% reduction in terms of your risk if you are exposed to it. Some of the data kind of talks to gonorrhea as well, and we have pretty high rates of gonorrhea. But the gonorrhea data is less effective, and that's because most gono is resistant to doxy. So depending on where they did the study, some places they didn't have really resistant gono, so the numbers worked well. US is pretty resistant, so the numbers are around 55%. So reality is you don't use it for gono. Where it's going to have its most effective is in the syphilis space and the chlamydia space. Again, this data is mostly MSM because a lot of it came out of the IPRGay study out of Montreal for PrEP, where they're doing the 211 stuff. That's where they kind of saw it. They've done some other doxyvax studies where they got more data, which is where some of this has come from. There's been one study out of Japan looking at sex workers, and they showed a 65% reduction in that community. So there's not a lot of data for women as yet, but it's coming. So at this point in time, it's a tool that we should be using for people to nip syphilis in the bud, essentially. This is how you take it to 100 milligrams, 200 milligrams, up to 72 hours, ideally within 24. US says don't take more than 1 dose per day. In New Zealand, we're saying don't take more than 3 doses a week. So every 72 hours you could take a dose, and that would be effective. The good thing is, here's some of the precautions around it. You take doxy on a full stomach with a full glass of water. You don't lie down for an hour. So esophagitis. It gives you're more sensitive to sunlight, so you might use more, avoid the sun or wear sunscreen, and avoid dairy products. So there's no tests you have to do before you start it. It's not like PrEP with kidney function and stuff like that. It's pretty innocuous. And the good news is Sexual Health has come out in support of it by producing a statement, right? So this was, Australia brought out a statement, we brought out a New Zealand version of that statement in support of it and how to use it for particular audiences. We want to minimize how much it gets used, so it's not everybody, but the people who most need it, who are at most at risk of syphilis, get access to it easily. GPs can prescribe it. It's because it's used for everything. It's pretty easy to get. The thing we don't have is guidelines on how to actually prescribe it. So there's mixed messages on that. So in the statement, it says to give out 72 pills for a 3-month period. So that's every 3 days you're getting 2 pills. So that adds up to 72 for a 12-week period, which is kind of confusing. Some doctors give out 30 pills, some people give out 40, some give out 90. So it's a little bit mixed because we don't have procedural guidelines, which is what they said in Australia. They haven't really picked it up and run with it yet because they've got the statement, but they don't have the guidelines. So the doctors don't know how to do it. So we don't want to make it hard. We want to make it easy, accessible, and we want to get rid of syphilis. So there's my 2 cents on DoxyPEP. So, any questions? It's from a community perspective as well. I'm not a doctor. All right. Yeah.
Trans imaging.
There's not a lot of data. So for people with vaginas, there's not a lot of data. But yeah, that's the problem because it was mostly through looking at gay guys, so people with penises. So that's where the data's come from in terms of the vagina space. But that data's going to come really, really soon. So watch this space. Yeah.
What is the current uptake? How many people do you think are using it at the moment?
We have no idea. So we know there's lots of interest. There's lots of people asking about uptake of doxy. The problem is because it's prescribed for everything else, you don't know if it's being prescribed for a rash or is it being prescribed as prophylaxis. We don't know. So, yeah, that's the challenge. But I know a lot of doctors, GPs are prescribing it, which is great. So, yeah. Yep. Uh-oh. Question from Jeannie. Yep.
Is that on? Oh,
Yep.
yeah. But just to say that at Sexual Health, we rolled DoxyPEP out 4 months ago, So I think we've prescribed in the first 4 months 114 prescriptions so
Yeah.
far. So we're just coding them so we can audit it and see who we're prescribing to, who's missing out, and
Yeah.
potentially, what the, incidence of infections is going forward.
Yeah. So the main concern that people have is a long-term use of an antibiotic. What will that have effect on your gut biome in terms of long-term use of an antibiotic, and the potential for resistant gonorrhea, more resistant gonorrhea, because we have lots of it already. Will it create more resistant gonorrhea, and could it have a flow-on effect to other things as well? So that's kind of the post-market surveillance that we need to do. But what they're doing in San Fran is saying, well, basically we've got rid of syphilis. That's the big thing. We'll worry about these other things as we move forward. And then potentially we won't need DoxyPEP at that point, right? Because we don't have it the rates that we're having now, right? So now I wanted to talk a little bit about Fiji. These aren't my slides. I was at this conference in Sydney. Like I said, the Minister of Health in Sydney presented them. It was quite crazy. And I did a little bit of digging, and it's just the tip of the iceberg, really. So, yeah. Anyway, so the challenge in the Pacific Islands, so I'm going to quote, that's what I can remember what she said, is the remoteness. There's low incomes. Most countries are dependent on remittance payments. So there's a lot of back and forward. So people sending money back to the islands, coming here, working as RSC, seasonal workers going to Australia, working there, sending money back to their families. Lots of back and forward, right? Fiji's a hub, right? So it's a hub to the rest of the islands. So why don't I make notes? Anyway. It's a hub for the other islands. So people come in there, that's where the education goes out. So there's lots of travel to Fiji and then out to the other islands. So that's a really important thing to think about as we go forward, right? So they're sending out skilled workforces and shipping and airlines going to the other islands from Fiji, right? So in terms of what's happening there, there's low rates of HIV historically, but they need more research, really high rates of chlamydia, no testing available for chlamydia except for in Palau, right? Which is scary. So they need a mass treatment strategy, so ongoing chlamydia screening required, and they need a chlamydia vaccine, right? So that's where the focus came from the Minister of Health. In terms of HIV, so these are their numbers. So this is from 2017. They've had a 573% increase in HIV numbers since 2017. So in 2022, that was around 243. 2023, that was 415. Up to June 30th of 2023, they had 552 cases. Local transmission, local diagnoses. The scary thing with this number is what the minister said when they put this press release out. These are symptomatic people that are coming in for testing, right? So it's not a screening thing. This is the tip of the iceberg, right? That number is symptomatic people. So 552. So they've had people as young as 9 and 10 diagnosed. So most of them are adults. So they're going to peak at around probably over 1,000 this year in terms of diagnoses. 900,000 people live in Fiji, right? So yeah. In terms of when they looked at how the transmission was happening, this is the data they presented. Only 85 presented as being from needle use, from sharing needles. Most of them are unknown, right? So people weren't comfortable talking about the situation that they were in that might have exposed them to HIV. So you can do the math. In terms of the next crazy piece, so of the people that they know that are diagnosed, so 690 people are diagnosed. 600, so we had 550 people diagnosed this year. Of all the people that have had diagnosed, only 690 are engaged in care, right? So 33% of all the people diagnosed are in care. So 84% of those are on treatment, 39% of those on treatment are virally suppressed. So when you look at the 90-90-90s, that's not that number, right? That's a 33, 84, 39. So, and this is, the trajectory is not going the right way. So in terms of their gaps and challenge, So the government's come on board and committed that there's a problem, and stated that they're going to do something about it, and they're looking at ways to do that. So they need leadership and governance, so that's really good. They need an increase in financing. One good thing is they've just got a grant for $5.2 million from UNDP, United Nations, to do some work, which is great. They don't have an information system. They have stockouts of testing kits and medications. Their health workforce is dependent on sexual health. They lack basic training in HIV. And the service delivery clinics are not accessible. Outdated, minimal research, social behavior change content, right? So there's lots of problems. The thing I'm not seeing there is needle exchange. So it's like this big elephant in the room. Nobody talked about it. It was weird. That's the end of my slide. But I'm going to go back. Can I go back to that last one? Yeah, bounce to it. Yeah. So they've just got a grant from UNDP for $5.2 million. They don't talk about this thing here, that number where they say that on the statement they put out, as they said that people should refrain from Bluetoothing and chemsex. Bluetoothing is where what's happening. What's happening in Fiji is it's a meth hub. Essentially, it's a gateway into Australia and New Zealand for meth. It gets housed there. They said that the amount of meth that they'd found, because they've upped their policing really heavily. That's what you do when you've got a drug problem. You just do policing because we know that works. So they said they've found enough meth to cover off half of their GDP. So that's how much is there. And so what's happening is the cartels are using it, getting people addicted. But what they're doing is they're sharing blood. So they inject, draw back, and then inject the next person. That's what Bluetoothing is. And so that's how you share it. So that's that number there. The 89 people are doing that. The other ones aren't doing anything. They just got HIV magically. The scary part with these numbers, is that that's going to go up again next year. And Fiji's a hub, right? So if it's coming through the Bluetoothing space and through sharing needles, it's not going to stay in that space. It's going to spread through other networks fairly quickly across the Pacific, which includes New Zealand and Australia, but all the Pacific, right? This is a huge problem, and nobody's talking about it. So, there you go. That's me. Question.
I think that's exactly a fear. I was in a forum this week. There's a forum being held at the moment for Pacifica doctors in addiction, held by some Vincents, I think. And Jeremy Haler from Brisbane spoke about stigma, and I attended just to raise the issue. And the comments that we got was, I'm very scared of methamphetamine. So there's a lot of fear, and the message was like, we need to fight the dealers. And so I had to restrain myself to say we need to treat the dealers too, But because there is I don't know how we're going to overcome that. Hence, I'm trying to really, since you told me this, I just releasing the word everywhere. But it is they do nothing about having immunization in the Pacifica.
Well, and I think the reason I'm bringing it up here is because New Zealand has such a good track record with needle exchanges, right? We brought it in early. It's worked really well. We know how to do it. And so, like, we have NZAID, which does work with Fiji. Why can't we drop a needle exchange in there, right? Like, as an idea. Why can't we do that? So, because they're not talking about it, they're talking about more policing and controlling of drugs, but they're not talking about harm reduction at any point in these conversations that I've seen so far, which I think is a big problem. And I think that's kind of on us to be, not me, us, to be able to do that somehow, to actually make a change. Because otherwise, they're our neighbours, right? It'll impact us, and it's kind of what we're good at, so we should be able to help them. So, yeah.
I have something to say about that.
Yeah.
what I was doing a look into some of the data that has been released from Fiji, and I think like 80 to 90% of the cases were men.
Yeah.
And so, like, obviously sex between men is playing a major role as part of this, but it might not be addressed.
Yeah, most of the cases are amongst men, which I had a slide on. But is it through sex or is it through shared needles in that space? We don't know.
No, we don't know.
Because they're all the unknown, right? So they don't say, because it's stigmatized in terms of gay sex and it's stigmatized around drug use.
Yeah.
So, yeah.
No, I think it's both, and they're probably overlapping.
Yeah.
We reached out to Carl at Needle Exchange, and I know that he was going to have a conversation with Te Whatu Ora about whether we could do something. I have a feeling that there were some restrictions on sharing clean needles in terms of the regulations over there. I don't know, some people would know more, like Shan.
Yeah.
But yeah, I just want to thank you, because I think it is really important we find something to do and some ways that we can help and ways that we can support the locals. We're going to put it on the HIV forum agenda to see if we can come to something as well.
Cool.
Does that work? Oh, yes, thank you. Nisam Bulavanaka. I'm Fijian, we're Fijian. I've just come back from Fiji recently, like 2 months ago, and was in my village and doing sexual health promotion with the men in the village. And then I went in, around to different parts of Fiji. The assistant police commissioner is going around to all the churches, the universities, taking the stance around criminalisation, around the war on drugs and trafficking. When I sort of, would talk to elders in the village and then people who I knew working in the HIV NGO space around, harm reduction and needle exchange program, no one doesn't know what that's about, because the big focus is around criminalisation and drug trafficking. It's quite complex with our culture because it's dominated by men. And then, there's drinking kava is another thing. And it's quite complex because it's a heavily religious country. The other thing is, like, in Suva, Gawea, so it's not unusual for, like we call, people have been estranged from the village and come to the city. And so they, young people, like we just call them the street boys, street girls, they just come there, like they could be as young as 9 or whatever, and just selling drugs and injecting. So it's quite normalised, but the criminalisation of drugs and needles is really complex over in Fiji. I asked some of the local people who inject drugs where are they getting their needles from, and they get them from the pharmacy. If not, they'll steal them from the hospital. Woman, if they want to get on the contraception pill, it's 24 Fijian dollars from the pharmacist. And it's really complex. So if you have the district health nurse that's from your village, she's going to be drinking kava with you in some of our spaces where, they're related to us or stuff like that. So it's really complex. And the thing around, like Dal and I were saying that it would have to be like, Pacific-led, but also we need our allies from Aotearoa New Zealand, from top up, that we would be able to work with our peers and our clinicians, and also through the government as well around legislation reform, but also around the model. But Fiji desperately needs a needle exchange program, and I'd say in Suva in particular, because that's our capital city and the main port for everything.
One final one down here.
I was just reflecting, just quickly on a couple of things. One was with Western countries like, since Australia, New Zealand, so forth. I mean, if we think about when we were starting to deal with that, that sort of scenario, 2 things went through my mind. One is the response generally was pretty stigmatising, knee-jerk criminalisation, and a real resistance to needle exchange. And just remembering, I'm not sure about New Zealand, but certainly all the needle exchanges in Australia and every state and territory started as an illegal practice. like they weren't illegal for the first 4 or 5 years of operating. I'm not suggesting that you... but anyway. But nor did we have a health minister willing to to present this sort of data. So I suppose I'm just thinking, is there a sense that even if not, that obviously there's a conflict in terms of policing and some of the other sort of things, but is there a momentum or a moment that's happening at a policy level in Fiji that they're genuinely going to go there and deal with stuff?
So they're going to deal with stuff, but they're not going to deal with a needle exchange. So when I asked about a needle exchange specifically, they said they were thinking about doing an evaluation study to see what might work. So
yeah, all right.
That was
just to remind, needle exchanges were operating, I think, in New Zealand and Australia for about 10 years before we had any real studies. So yeah, that doesn't have to happen first.
Sorry, one of our universities, FNU, I went and met with the director in Lautoka, and he said to me that there's 1,000 students that drop out a year that end up getting involved in drugs, whether it's drug dealing, trafficking, injecting, all that stuff, because it's lucrative.
Yeah. Okay, so there you go.